Ladies and gentlemen, good morning and welcome to Nuclear Medicine Brain Imaging Lecture. Okay, so today we're going to talk about brain death and brain perfusion, and quickly we'll mention dementia, epilepsy, CSF flow, as well as tumor and radiation necrosis imaging. Okay, so the radio tracers that can be used for imaging of the brain, we have specific lipid-soluble agents, so that's technetium-99m, HMPAO, and also ECD or Neuralite, which is generally the preferred imaging agents. Again, this is lipid-soluble, so it crosses blood-brain barrier and specifically binds to the brain. FDG, again, we're really well familiar with it, and brain really likes sugar, so it will take up a lot of FDG, and the peak localization will occur at 30 minutes. There's also a variety of other agents, and particularly amyloid-avid compounds that are now used for imaging of Alzheimer's. Okay, let's start by talking about brain death, and there's a variety of guidelines that talk about it, and particularly recently in Pennsylvania, due to changes in some of the laws and regulations, we have started to see more brain death imaging. Okay, now the test, as everything, requires preparation, and this is taken straight from the guidelines. So make sure that prior to arrival for brain death scan, the patient is told to avoid caffeine, alcohol, and other drugs, as well as they should not be smoking for at least 24 hours prior to the scan. Again, critically important in my experience. Okay. So brain death imaging can be performed with blood pool agents, and this is historically used to be used for mostly DTPA, and this is just purely an angiography type exam. And again, brain-specific agents such as Neuralite that show uptake in the brain parenchyma. And these are the examples of normal and abnormal DTPA and Neuralite scans. And as you can see that for DTPA, we see intracranial vasculature, and for Neuralite we actually see brain parenchymal uptake, which is much easier to perform. Again, the language tends to be pretty important, so we can say that there is no brain death or that there is no evidence of brain perfusion, which is preferred based on the guidelines. Okay, these are the typical doses as well as the organs receiving the greatest amount of radiation. And again, these are a few practical examples, so I'm sure within a few seconds all of you correctly identified this as the brain death. Again, we see loss of gray-white differentiation on CT, and on the Neuralite scan we see activity in the scalp, but not in the brain parenchyma itself. Okay, this is another example. What would you say? And I'm sure all of you correctly identified this as a brain death. There is no brain parenchymal activity. Okay, how about this case? We see pretty terrible intracranial hemorrhage. However, we do see there is tracer activity in the posterior cranial fossa, so this patient is not brain dead yet. This is another example. Is this brain death or no? And I'm sure all of you correctly said no, because there is brain parenchymal activity. However, all you generally have to do is wait a few more days, and this is a correlation with CT scan. We see at the time of the Neuralite scan, there was still gray-white differentiation. In the 3 days, all gray-white differentiation is lost. Brain death scan was not repeated at that point. Diagnosis was made clinically and with apnea tests. Okay. Hot nose sign, again, this is people like to publish, so in a patient with brain death, there's increased flow in the external carotid, so there'll be increased uptake in the face. All right, so in summary, for brain death imaging, do not use blood pool agents, use use brain-specific agents such as Neuralite, and use delayed images for brain parenchyma. Makes it pretty straightforward. Okay, so let's quickly talk about dementias. And when imaging dementia, it's important to be familiar with brain anatomy on FDG scans and other scans. So for Alzheimer's, particularly important posterior cingulate gyrus, as well as being able to identify parietal lobes and temporal lobes. So these are the areas that's important to identify. This is the cingulate gyrus, especially its posterior portion, and the precuneus area in the parietal lobe. Okay, so in Alzheimer's, we expect to see decreased tracer activity in the bilateral temporal lobes, parietal lobes, and posterior cingulate gyrus. Posterior cingulate gyrus is the first affected, so that must be present. Okay, this is an example of Alzheimer's disease. We see decreased tracer activity in the parietal temporal lobes and the posterior cingulate gyrus. When Alzheimer's becomes more advanced, this can also involve frontal lobes, but again, key to identification is posterior cingulate gyrus and the temporoparietal metabolism, which is decreased. Okay, how about this example? Does this patient have Alzheimer's disease? And I'm sure all of you correctly identified yes, because there's decreased temporoparietal metabolism. What about this case? Does this patient have Alzheimer's, yes or no? And I'm sure all of you again correctly identified decreased temporoparietal metabolism, so this patient does have Alzheimer's. Amyloid imaging now has been around for a few years and initially started with carbon-11 labeled Pittsburgh compound. However, now there are FDA-approved FDG agents which are much easier to use. The scans still remain mildly controversial in terms of who should get it and who should not get it, and there are certainly guidelines for that as well. So this is the normal and abnormal scans. In normal scans, white matter has more activity than the gray matter. In abnormal scans, the gray the appearance is reversed, and the gray matter has more uptake than the white matter. So just look to see what's more prominent, gray or white matter. Okay, so this is a patient with suspected Alzheimer's, and A is MRI imaging, B is PET imaging, which shows decreased activity in the temporoparietal lobe. So this is certainly consistent with Alzheimer's. And then we see the increased uptake in the gray matter in comparison to the white matter in the bottom images, so this is consistent with Alzheimer's disease. However, this is another example where, again, MRI is unremarkable. PET in row B, in the middle row, shows decreased temporoparietal metabolism. However, note that the posterior cingulate gyrus is not affected. And then when we look at the Pittsburgh compound images at the bottom, we see that the white matter is greater than the gray matter, so this patient does not have Alzheimer's disease. And certainly we see that the amyloid tracer imaging is quite useful and relatively easy to interpret, actually. Okay, there's a variety of other dementias, and there's a classic description of FDG uptake patterns, although this tends to be pretty difficult in real clinical life. So in dementia with Lewy bodies, we can expect to see decreased uptake in the occipital cortices. So this is an example of dementia with Lewy bodies. So we can see hypometabolism in occipital lobes, in addition to the prefrontal, parietal, temporal, and the posterior cingulate gyrus hypometabolism. So again, dementia with Lewy body characterized by decreased occipital uptake as well. Frontotemporal dementia, again, classic appearance where there is a decreased metabolism in the frontal and temporal lobes, making it pretty simple to diagnose. So again, frontotemporal dementia is decreased metabolism in frontal and anterior temporal lobes, as evidenced on these images. Okay, corticobasal degeneration is pretty rare, fairly difficult to diagnose. It has characteristic decreased tracer uptake in the sensory motor cortex and ipsilateral basal ganglia and thalamus. Again, probably not going to be tested in this. This is pretty challenging. Posterior cerebral atrophy is characterized by decreased metabolism in the parietal temporal lobes, as well as the occipital lobes. Again, fairly rare and would be difficult to diagnose. This is, again, a visual summary that, frankly, I don't find all that helpful. So as long as you remember the Alzheimer's disease, frontotemporal decreased metabolism, as well as the posterior cingulate gyrus, you should be good. All right, so FDG scans can also be diagnosed for evaluation of tumor recurrence versus post-radiation. Necrosis on MRI imaging, both can look relatively similar, so PET scans can be quite helpful. And you see that in this particular case, despite presence of enhancement on MRI, there is no increased FDG uptake in the area, so this is a post-radiation necrosis. Okay, how about this case? Again, we're seeing area of necrosis with nodular peripheral enhancement. So is this radiation necrosis or tumor recurrence? And on a PET scan, again, we can see that there is no increased tracer uptake in the area, suggesting that this is a post-radiation necrosis. When we look at the actual research data, it does turn out that, probably PET scans are not quite as good as we think. We're probably better off using not FDG, but synthetic precursor compounds, which are presumably slightly better, as evidenced in this particular case, where we see carbon-11 methionine PET, where we see increased tracer uptake consistent with tumor recurrence. And yet another example where, again, PET is clearly showing synthesis in the area of enhancement indicating tumor recurrence. Okay, epilepsy imaging. In epilepsy imaging, we perform both ictal and interictal imaging. So again, we most often use Neurolite, and in the immediate post-ictal imaging, the area that's causing an epilepsy shows increased uptake. So again, in the ictal imaging, there is relatively short-lived increased uptake. In the interictal imaging, the same area should show decreased uptake. Now, ictal imaging is superior to interictal imaging, but ideally we will use both. FDG PET can also be performed in the interictal state and will show decreased tracer activity out of proportion to atrophy if it's present. So again, this is an example where we see ictal exam showing increased tracer uptake and the interictal exam showing decreased tracer uptake, and we see cross-cerebellar effects as well. Okay, this is another example where we see interictal imaging showing decreased tracer uptake, although this is extremely subtle. However, ictal scan shows increased tracer uptake in a combination of both, using subtraction imaging, where we can easily identify the focus of epilepsy for surgical intervention. This is PET scan. This is medial temporal lobe sclerosis. The MRI is abnormal. However, the abnormality on PET is relatively easy to detect, and where we see decreased tracer uptake in the right temporal lobe in comparison to the left side. CSF flow tests, they are performed with intrathecal injection of radiotracer, and then or injection of the shunt reservoir by neurosurgeon, and then we can follow the CSF flow or identify the leak, particularly if we're using pledgets that are packed in the sinuses and then removed by an ENT surgeon, and then if we're imaging the pledgets, we have an increased ability to detect the leaks. Okay, so in summary, brain death will use a lipophilic agent such as Neurolite that bind to parenchyma and cross blood-brain barrier. Remember that for Alzheimer's, we see decreased uptake in the posterior cingulate gyrus as well as in the temporoparietal lobes. For amyloid imaging, the tests are abnormal if cortex shows more uptake than the white matter, and for dementia with Lewy bodies, we will also see decreased visual cortex uptake For tumor recurrence, carbon 11 methionine is probably superior to F18 FDG, and for epilepsy in the ictal state, area of epilepsy will show increased uptake, and the interictal scan, this area will show decreased uptake. And certainly FDG is an excellent test as well. All right, thank you very much for your attention.